Hi, good evening, everyone. My name is Dr. Vedhika Shanker. I'm a junior consultant pediatric anesthetist at NHSRCC Children's Hospital, Mumbai. So I have a background in pediatric anesthesia as well as in regional anesthesia. And I use a lot of pediatric regional in my daily work. So the topic for today is pre-medication in pediatric anesthesia. And more than the theory of it, I am going to talk about how we run pre-medication on a practical basis and how we make a call as to which patients require what kind of pre-medication and what are the options available to us. So first and foremost, this is, can you see my full screen, Mukta? No problem? Or are some of the words getting cut off? All right. So again, this is a still from IAPA-Con 2024 that was conducted in Noida. These are two very senior, very well-reputed anesthesiologists, Dr. Nandini Dave and Dr. Jayanti. And this is how they sat for a Meet the Experts session on pre-medication in pediatric anesthesia. And what I'm trying to get here with this picture is to tell everyone that you are dealing with children. Don't be afraid to let your hair down a little and engage with your patient. That could make all the difference in your anesthesia management. All right. So a special thank you to Dr. Nandini Dave, Senior Consultant and Chief of Anesthesia, NHSRCC Children's Hospital, for all the videos, clinical experience, and most importantly, for all the mentorship she provides. So this is SRCC Children's Hospital. We are a 210-bedded tertiary care pediatric unit, and all the pictures and videos and clinical experiences I have will be experiences from this hospital. So when it comes to anxiety before surgery, the current literature states that we are looking at about 70% of all children demonstrate stress and anxiety before surgery. Now, first, before we go into how many patients, we also have to look into the risk factors and how you identify high risk or more at-risk children who will be anxious. Child factors, parental factors, and perioperative environment factors, these are how we can divide the various subdivisions within these risk factors. So under child factors, we know that separation anxiety begins at about 9 months and peaks at 1 to 5 years. You will find that your most reticent patients tend to be in the age group of 1 to 3. All right. Temperament of the child, naturally, that is going to predispose to anxiety. If the child is, in general, anxious, a little more prone for crying fits, has temper tantrums, you're more likely to expect anxious behavior preoperatively. Children who have had multiple previous medical encounters, specifically bad ones or ones wherein the pre-medication was not looked into or the post-op period was stormy, a prolonged ICU stay, these children are particularly anxious, and you can hear them crying as they're being brought into the preoperative unit itself. And biologically based vulnerability comes with respect to those patients who have neurodevelopmental disorders, and behavioral disorders, for example, ADHD, autism spectrum disorder, developmental delays, etc. Now, parental factors is where this gets interesting. Anxiety never exists in a silo. So when parents are anxious, it typically rubs off on the children as well. So when you have increased parental anxiety, that itself correlates with increased anxiety in the child. And the factors that are most associated with increased anxiety in the parent includes, a family which has marital discord, single parent homes, divorced parents. Mothers tend to be more anxious. Parents of infants tend to be more anxious, and parents of children who have needed repeated hospitalization. All of this is fairly intuitive and, makes a lot of sense. And the things that, us as anesthesiologists, we don't realize that we have the power to change these factors, but we, can have a significant impact in this area, that is the perioperative environment factors. A very stimulating external environment. Too many patients, specifically if your pre-op and post-op areas are next to each other and you have a crying child in the PACU and, the preoperative area is visible. Children who are looking at these crying children post-surgery can get really anxious from this. So one, try having privacy dividers wherever it is safe and possible so that the pre-op area is separated from the post-op. Ensure that it's your calm environment, there's not too much noise. Ensure that, whenever possible, time between admission and surgery for your daycare cases is limited. Induction technique matters. Adequately pre-medicate the child, give the option of the child, to have a look at the OR. All of these matter as well. The experience of the anesthesiologist as well as the attending personnel matters a lot. If you have a staff collection who are comfortable dealing with children, who know how to handle them, it makes a huge difference in how your intraoperative and postoperative course will go. I have a few videos describing this. As we go forward, you can have a look for yourself. So now that we have covered the risk factors, let's go into what we already know about pre-induction anxiety, a stormy separation, and an anesthesia induction. So a stormy separation, can trigger airway events. Child can cry. Because of excessive crying, you can have aerophagia, excess secretions, and this can lead to perioperative respiratory adverse airway events, or PRE. Then you have emergence agitation is increased because a child who goes under anesthesia kicking and screaming is not going to come out, very calmly. Postoperative pain is worsened when anxiety is more. The idea behind this is that pain as well as anxiety are also routed through your sympathetic nervous system. Obviously, so when you're anxious and your sympathetic nervous system is in overdrive, your postoperative pain is also going to be impacted and be worsened. And more dramatically, I would say, beyond the perioperative period, you also have short and long-term behavioral effects. Postoperatively, children can have new onset enuresis, nightmares, generalized anxiety disorders, and this can really persist. Where this becomes particularly, alarming for parents and dangerous is we see children when they require anesthesia and surgery. But oftentimes when children are coming for multiple sittings, like a plaster removal or, plaster casting for, say, for example, something as simple as a club foot, we only see them for the surgical component. They do, however, require multiple hospital visits, and each one of these hospital visits can be pretty daunting for the family when each visit triggers a massive bout of anxiety in the child. Patient and family dissatisfaction, obviously, for a child is going to have a triggered experience every time they come to the hospital that makes compliance with treatments also more difficult. Difficult induction with subsequent anesthetics is also likely, all for the same reasons. Once you have triggered one bad memory, you have a sort of an association that develops that all my surgeries and anesthetics are going to be very traumatizing. So this is the 10N principle of pediatric anesthesia. This is from safethoughts.org. It's an American website that, it's a website that you have access to all. It's an American-based program. And these are the 10 N's for quality of pediatric anesthesia. And as you can see, the first one is no fear. Okay. And this is something all of us have to remember, that though the child has to come for surgery, we're hoping to make them better, we're also looking to make this a more pleasant experience for them, or as pleasant as possible. So let's start at the very beginning, which is our pre-anesthetic checkup. Now, a good PAC forms the cornerstone of a good anesthetic. Spend time talking to the family. This is the first encounter, is the best time to make an assessment as to how to approach your pre-medication. So if you're sitting in the room and you have a family walk over, at this first meeting, you can either have one member, two members, multiple members. That itself gives you an idea as to how anxious the family is likely to be. The younger the child also, the more likely the patient is going to be anxious. So the minute you sit down, you introduce yourself, ensure that you try to introduce yourself to the child as well if they're over 2 years old. This immediately helps you develop a rapport with the patient and the family. This is also the time to speak to the parents about the possibility for dual pre-medication. I'll come to this concept of dual pre-medication a little later, but if you're planning on giving two medications at staggered intervals, this first PAC is where you can probably gain an idea.